Hello and good day to you. This is Tracy Harrison from the School of Applied Functional Medicine, and I want to invite all progressive healthcare practitioners to join us for this featured topic, which is going to be all about the gut. The functional medicine lens makes clear to those of us who study it that so much systemic disease, not just gut-mediated disease, but systemic disease actually has its roots in our gastrointestinal tract. Often what happens in the gut simply doesn't stay there and it spreads systemically. I'm going to do a deep dive into some key practitioner insights that we believe all practitioners need to know in order to ensure that you are able to bring the best capability and confidence you can to support your patients and clients. We've had the pleasure and privilege over the years to support a very diverse audience of healthcare practitioners. In fact, I think the simplest place to begin is often with myth busting. It's perhaps surprising, perhaps not, that so many practitioners, when talking about dietary choices and a need for nutritional changes, we often tend to just focus on changing the diet, changing the food, changing what we put in our mouth. However, that often belies an assumption that is often not true, which is that if we're putting a certain food in our mouth that is loaded with certain nutrients, we can well assume that those nutrients are actually going to make their way into our cells and support our biochemistry. But nothing could be further from the truth. And if you have been studying functional medicine for quite some time, then you are well aware of the fact that the old adage that you are what you eat is woefully oversimplified. We are not what we eat. We are what we consume, digest, absorb, convert to final forms, and get past the cell membrane, which is a much higher hurdle. And indeed, one of the largest, simplest reasons why the systemic body could be struggling is due to lack of sufficient nutrients needed to drive various biochemical processes. When we think about food or talk about food culturally or even conventionally, we're often thinking about calories and a focus on macronutrients. But certainly our metabolism may run on macronutrients, but our biochemistry runs on micronutrients. And as we like to say, no lettuce, no salad, right? If you don't have the ingredients that the body needs in order to drive specific processes, then indeed we are going to suffer. If we don't have enough magnesium actually making it into our intracellular environment, then we're going to struggle to convert vitamin D to its final forms, and therefore we're going to struggle to have optimal immune function. If we're not bringing on board optimal levels of the mineral selenium, then we're going to struggle to have optimal synthesis and metabolism of glutathione, the most important intracellular antioxidant. If we don't have excellent digestion and absorption to bring on board certain amino acids like tryptophan, then we're not going to be able to support the synthesis of serotonin to support our neurotransmitter sufficiency and the different downstream effects and lifestyle balances that we need serotonin for. And so this is an important consideration. We can eat the food, but we have to be able to digest the food, break it down into key nutrients, and then be able to absorb it. And this is where we often overlook many different root causes of maldigestion. And so this can be, in particular, dynamics such as hypochlorhydria. Sorry about the puppy noise. This can be dynamics such as hypochlorhydria, where we simply don't have enough stomach acid. The gastric cavity is not acidic enough in order to properly denature proteins, in order to allow our digestive enzymes to cleave those chains into individual amino acids or into polypeptide chains that we need to nourish the body. Stomach acid is sort of a lowly substance, but the reality is an awful lot of your patients and clients today use medications that purposefully create hypochlorhydria, that purposefully is creating maldigestion, whether it's a proton pump inhibitor or an H2 receptor blocker, taken in the name of reducing acid reflux symptoms, we are creating maldigestion. And so this not only can leave us downstream struggling with inadequate availability of certain amino acids, but it can also leave us wrestling with different symptoms of that hypochlorhydria. In particular, an early sense of satiety and fullness after eating, quite a bit of belching. Hypochlorhydria might actually create acid reflux, which promotes the usage of more medications, which exacerbates it in a vicious cycle. But hypochlorhydria is just one example. We can also have inadequate levels of digestive enzymes. Well, let's talk about that for a moment, because even if we have optimal levels of stomach acid, we still have to have plentiful digestive enzymes in order to actually degrade and food and isolate those nutrients that are needed so that we can absorb them. But one of the most common reasons why individuals can have an exocrine pancreatic insufficiency is downstream from metabolic disease. Yes, absolutely. Research shows that individuals with any type of diabetes, this is type 1 diabetes, autoimmune damage to the pancreas itself, as well as all different stages of type 2 diabetes, is 25 to 50% of these patients can actually also have impaired exocrine or digestive function from the pancreas, not just challenges with insulin. And so this is a great example. If we're not looking for a disease dynamic in our patients, we won't necessarily find it. And so we want to be looking in every individual who has metabolic disease to see if indeed there is an actual inadequate pancreatic enzyme secretion as well, because we need those enzymes in order to degrade food, to mobilize those nutrients so that they can be absorbed. But it goes even further than that, right? We also need bile in order to be able to help us to emulsify fats in order to absorb fatty acids. But I want to take a moment to talk about bile, because many individuals in our cultures today, in our practices today, have undergone cholecystectomies. And if they haven't actually removed their gallbladder yet, they may be struggling with various stages of gallbladder disease or dysfunction. One of the most common upstream root causes of that is hepatic biliary congestion. Individuals with metabolic disease and all different stages of fatty liver, which often is more brewing at a more subclinical state in the early stages of insulin resistance. But as the liver becomes more congested with fatty infiltration, it becomes less capable of optimally synthesizing bile and supporting its flow from the liver through the biliary tree into the gallbladder. And so again, we want to be looking for the possible hepatic biliary congestion that might be leading to poor bile function downstream. Another common point of interconnectedness is your female patients who may be struggling with higher levels of estrogen or estrogenic activity. This is where we can end up with hormones influencing the concentration of cholesterol in bile. Research shows that we can end up with a higher level of cholesterol in bile. Cholesterol is a critical ingredient in bile, but the recipe, the ratios of the ingredients in bile are necessary not only for its biochemical function, but also for its viscosity and flow through the hepatic biliary tree and easy emptying of the gallbladder. Well, higher estrogen states encourage a greater level of cholesterol in bile, which can make it thicker, more viscous. And this can actually contribute to poor gallbladder emptying that over time can lead to a higher likelihood of gallstones and potentially gallbladder disease. This is the type of thing through the functional medicine lens that you can learn to thoroughly understand, look for proactively in your patients and clients, and help them to avoid surgeries that ultimately may not be necessary by simply preventing the progression of disease that is at play. And so when we think about multifactorial aspects of digestion, right, the stomach and stomach acid and the enzymes produced there, and pancreatic enzymes and bile, we also have to go down into the small intestines, where the precious brush border of our small intestines in particular is where we produce a lot of enzymes. For example, lactase, that is needed to digest lactose found in dairy foods so that those foods are well tolerated. Or sucrase, that is needed to digest sucrose found in so many popular foods in our sugar-loving cultures. But the gut lining is also vulnerable to damage. And I want to go back to the possibility of medication-mediated dysfunction. Many individuals in your practice are routinely using non-steroidal anti-inflammatory drugs. In particular, medications such as ibuprofen. In fact, we often remark through the functional lens that when you're doing a thorough intake with a patient, that they often don't mention that they use certain types of medications, especially those they purchase over the counter themselves, like ibuprofen. Many individuals use ibuprofen prophylactically every day, just in case, or because generally they have a lot of aches and pains, without realizing just how corrosive these medications are to the gut lining. Certainly they can be effective for temporary pain relief, but it is at a dramatic cost because they directly impair the body's ability to heal mucosal integrity in the intestines. And so this is where individuals can be using these medications. They may not even think to share that with you because they don't think about it as being a drug because it's so commonplace. And this can be causing damage to the lining of the intestine and actually rendering our brush border with oxidative damage, and we are unable to produce optimal levels of brush border enzymes. And this can directly cause maldigestion, a fascinating point of interconnectedness. And in all of these states, again, we have to disconnect and understand that what we eat is not necessarily the nutrition that we are going to be making available to our systemic body. Now, another key component I want to mention about the brush border is that this is also where we produce a powerful enzyme called diamine oxidase. And one of the ways in which what happens in the gut doesn't stay in the gut is as a result of high levels of histamine. Now, the gut tends to be an area of the body that frequently is dealing with a bolus load of histamine because we consume histamine in our food and beverages. Our microbial friends and our microbiome in the gut are producing histamine. And as we know, over 2/3 of our immune cells typically are lodging in the intestines. And so this actually, of course, our immune cells are producing histamine as part of their normal reactivity to substances they perceive as being stranger and danger. But what this means is that the gut needs good, efficient, readily available ways of dealing with histamine overload. Because when we have excessive levels of histamine in the gut, this also damages the mucosa and can contribute to a loss of barrier function in the gut. Well, we do have a specialized way of degrading histamine in mucosa, not just in the gut, but also in the nasal respiratory membranes, in the mouth, in the bladder, and the urogenitory tract as well. But in this mucosa, we produce an enzyme called diamine oxidase, which degrades histamine, assuming you make enough of it. But when you have damage to the gut lining, such as can be caused by NSAIDs, our ability to produce diamine oxidase can be damaged. And this can lead to an overload of histamine in the gut that can contribute to bloating, cramping, diarrhea, but again, can also help us to cultivate loss of barrier function in the gut. And this is often the pathway via which lots of gut-borne inflammation doesn't stay in the gut, but rather begins to affect us systemically and can contribute to dysfunction or impairment in pretty much any tissue in the body. And so we want to be paying attention to individuals who may struggle with histamine overload. Now, we often think about symptoms such as nasal respiratory congestion, chronic throat clearing, individuals who are hoarse, individuals who have chronic postnasal drip, or frequent headaches, or sinus congestion, or eustachian tube congestion and impaired hearing. Yes, these are all classic histamine symptoms, histamine overload symptoms. But you may not often think about histamine overload presenting as other symptoms such as anxiety or poor sleep. It's important to realize that histamine is actually stimulatory, right? The immune system uses it as a stimulatory response in the name of protection. And so when we have excessive histamine, we can have trouble actually relaxing the brain enough to have good, sustained, deep sleep. And in fact, across a typical diurnal cycle, our levels of histamine are highest in the middle of the night. And so we need good ability to degrade histamine in order to prevent overload so that we don't have trouble with mood imbalances and excessive anxiety, and we don't have trouble with impaired sleep. That is a often overlooked contributor or true root cause of insomnia. But we need to have good mucosal integrity, right? We need to have a healthy brush border in the lining of the intestines and maintain good ample barrier function in the intestines in order to counter histamine. And so it's an important point of interconnectedness to look for in your patients and clients. Now, I want to talk more about what can go wrong in the lining of the intestines, because there's a number of factors here that are important to consider. And this brings us back to the fact that barriers in the gut help us to form and then maintain good protection. Various cavities in the body need to be separated one from another in terms of a variety of pH environments, variety of different immune function, exposure to different immune cells, different enzymes. The old saying of good fences make good neighbors is actually accurate. We want to have good barrier function, separating the various cavities within the body. And perhaps one of the most important places to have that is in the gut, and having good barrier function in the gut. Because inside the gut, we are constantly, our immune system on our behalf is constantly at war with the microbial world. Constantly trying to keep peace on the playground, as we like to say. Any microbial species wants to grow and thrive, and there can be all sorts of opportunistic overgrowths. There can be transient pathogens. There can be temporary blooms or biofilm, increased population of various potential pathogens. The immune system is constantly doing battle in the gut. If we were to look at it up close in video, it would probably look like a cheap, B-grade science fiction movie, right? Where our immune system is constantly defending us, even when we are unaware of it. But this means there's a lot of debris being created in the gut. We are constantly killing off various microbes and freeing the various pieces and parts of various microbes. There is a tremendous amount of different inflammatory mediators being put out by our immune cells. There's all sorts of immune complexes in the gut, and the systemic body thrives best when there's strong barrier function that keeps all of that inflammatory melee localized in the gut. But what happens if you start to lose barrier function in the gut? Those tight junctions between the villi and the gut suddenly become more permeable. And we end up with an overexposure to our immune system and eventually to the systemic body of what should be isolated in the gut. Then this can actually be the root cause of a whole host of downstream dysfunction in the body. And one of the most common manifestations of this is pain, joint pain in particular. Joints are areas of low circulation. And so when there's a strong immune reactivity in the gut, and we end up, unfortunately, having more permeability, and a lot of that inflammation actually escapes, if you will, into the systemic body, then these are immune complexes. They're inflammatory compounds. And these complexes can easily be trapped in the body in areas of low circulation, like joints. And so this is why we often say through the functional medicine lens, if you don't know where to look, look in the gut. If you don't know where to begin, begin in the gut. Because in the vast majority of cases, not all, but in the vast majority of cases, there are strong roots of disease in the liver, disease in the brain, disease in the kidney, disease in the left knee joint, disease in the big right toe, disease in the eye. There are roots of these diseases in the gut, and that may seem far distant in the body, but it's actually quite interconnected in the biochemistry. Now, one of the powerful mediators of inflammation in the gut is bacterial debris. And of course, the immune system is well adapted in the gut to be able to keep peace on the playground and to counter overgrowths and to attack pathogens. And the enterocytes lining the gut are a type of cell that is able to have a strong immune upregulation via a mediator called NF-kappa B. And in general, that function is reserved for immune cells and gut cells and just a few other places in the body. This makes the gut a very powerful police station, if you will, or control center for the gut and for regulation of when the immune system needs to go into overdrive in order to counter a strong threat. And so enterocytes in the gut are very reactive to various types of microbial debris, and in particular lipopolysaccharides, or what we often call LPS, right? It is in fact so pro-inflammatory, we think of it as a toxin. We call it an endotoxin, right? An endogenously developed toxin. And when there is a lot of immune reactivity and battle going on in the gut, we're killing off a lot of microbes and we're freeing up a lot of lipopolysaccharides, which is going to be triggering the lining of the intestines to get alarmed and to generate a lot of NF-kappa B, which tells our immune system to go into more aggressive overdrive with higher levels of inflammation. Now, if all of that is isolated in the gut to counter some type of pathogen, that's a great thing. And undoubtedly it helps us to survive. But what if there's greater permeability and we're generating lots of a more aggressive inflammation because of the warfare that's going on in the gut? When lipopolysaccharide leaves the protected gut environment and gets past that barrier, the fence is down, and the systemic body begins to get overloaded with lipopolysaccharide, then we can end up with inflammatory damage to the heart, to the liver, to the blood-brain barrier, to the lining of our blood vessels. This can be involved in mediating all sorts of different pain syndromes, right? Because this can actually cause dysfunction in the mitochondria in our intracellular environment. It's a powerful example of how what happens in the gut does not stay in the gut. It leaves the gut and wreaks havoc. And so this is where it becomes really critically important to protect the gut lining. When what happens in the gut doesn't stay in the gut and we get greater, for example, lipopolysaccharide and other bacterial debris circulating throughout the systemic body, then we get greater inflammatory response to protect us in the systemic body. And research shows that this greater level of inflammation can actually go out and start damaging other barriers in the body, in particular, the blood-brain barrier. And as you might imagine, of course, this is a serious problem. There is a known gut brain, or some people would say a gut microbiome brain axis, where elevated lipopolysaccharide can trigger higher levels of certain inflammation like interleukin 6 that can increase the permeability of the blood-brain barrier. And now what happened in the gut did not stay in the gut. It went systemic, but now it's getting into another precious cavity that is supposed to be very well protected by another semi-permeable, well-maintained barrier. That blood-brain barrier. And this is when various inflammatory molecules, various toxins, other pro-oxidative debris can get into the brain and absolutely cause cognitive dysfunction, cause mood imbalance. An awful lot of anxiety and depression begins in the gut, for example. And so we want to be looking for the gut. Whether your expertise is neurological function or metabolic disease or autoimmune disease or fertility, we all have to learn to master the gut. Absolutely, right? Migraine, acute anxiety, seizure, Parkinson's disease, all of these kinds of things have roots in the gut. And so I share these examples with you to bring us back to reflecting on how essential it is that we think about gut barrier function in every patient and client we serve. If we're thinking with a broad-based functional medicine lens about the criticality of barrier function and why it's not innocuous to take an ibuprofen every day just in case you have aches and pains. There is a tremendous cost of using those medications. Well, let's expand this topic and talk about other medications that can wreak havoc on the blood-brain barrier, because it's not just about non-steroidal anti-inflammatory drugs, right? We have to also consider this for antibiotics. Antibiotics can also increase damage to the mucosa, participating in the worsening of malabsorption, but also creating enhanced intestinal permeability. So thinking very carefully about where are antibiotics absolutely necessary, because they come at a price. But it goes beyond that. What about steroidal medications, right? What about estrogen-containing oral contraceptives, right? All of these medications and many more wreak havoc on the integrity of the gut lining. And part of this is a very unfortunate consequence of our, in general, sort of pharmaceutical industry practice of using the gut as a coin slot for medications. as though it's a benign intervention. It's a benign pathway for getting medications into the drug. And nothing could be further from the truth, because while these medications may be absolutely well-intended and appropriately prescribed and may provide very beneficial effects in the body, especially for triage and intervention and to stabilize a disease or an emergency situation, it is at a cost in the gut. It is wreaking havoc on the way to serving other functions in the body. And so we want to use great care in thinking about when is it worth it to take that risk. And then on the other side of those medications, not using them for any longer than is absolutely necessary. And then when we're done, healing the gut. This is almost never done in a conventional type of dynamic, right? We use the medication short-term or long-term, and we don't stop to think about what whole secondary and tertiary disease dynamics are being created by the fact that this drug that was prescribed for the brain or for the elbow or for the liver or for the big toe is wreaking havoc on the gut and triggering a cascade that's going to set off other disease dynamics, especially with ongoing use. We have to start thinking about this in clinical practice. And it's a powerful point of interconnectedness that we're really passionate about teaching practitioners here at the School of Applied Functional Medicine, because being confident and feeling truly capable about casting this much broader, more intense lens on how does disease actually evolve in the body. Not just naming it, blaming it, and taming it, but why is it there? What are the actual roots in this unique person? And how can I get at those roots and actually make it go away so that I don't have to manage it long term? I don't have the risk of those medications. I can actually get rid of the roots of disease at their core. Too often we still believe that that's not possible, and that is not true. Our practitioner forum at SAFM is flooded on a weekly basis with people celebrating type 2 diabetes gone, asthma gone, autoimmune disease in full regression, right? Migraines gone, heavy menstrual cycles gone. We absolutely can culture and cultivate a savvy clinical partnership between practitioner and patient and do a much more thorough systemic look at the roots of disease in every unique person and get at those roots and resolve it. Not just improve it, not just manage it, but resolve it. Once we end up with a loss of barrier function in the intestines, then it's not just a matter of what other barrier function can be damaged, like the blood-brain barrier, but also taking a look at what types of immune hypervigilance do we create. Because when we have a loss of optimal intestinal permeability, what the other thing that's happening with these loose junctions, right, this greater permeability, is that we can end up with overexposure to the immune system in the basement membrane of the intestines, our gut-associated lymphatic tissue. We can end up with overexposure of the immune system to partially digested food. And internal to the protected cavity of the gut, of course, there's all sorts of states of digestion happening, right? There's enzymes going, there's immune cells checking stuff out, there's microbes challenging. It's crazy chaos in there. And the immune system has learned to tolerate partially digested food in the lumen of the intestines. But when we end up with greater immune system exposure in the basement membrane and systemically to partially digested food, then the immune system appropriately sees that food as both stranger and danger because it is partially digested. The immune system is used to seeing a certain mineral or a certain amino acid or a certain fatty acid, but the immune system is not used to seeing partially digested cheese, partially digested wheat, partially digested chicken or eggs. And it appropriately flags this as both stranger and danger, which sets off an immune system response that creates an ongoing adaptive immune reactivity to that food. And this is how we can develop food sensitivities. Usually either IgG or IgA mediated food sensitivities. This is a major cause of systemic aches and pains, but it can also contribute to low energy and fatigue, to poor sleep, to headache and migraine, to itchiness on the skin, to exacerbation of autoimmune disorders or new onset autoimmune dynamics, because there can be cross reactivity between the immune system responding to a food and an immune system responding to an endogenous tissue. And so this is how an individual can become reactive. The immune system can become hypervigilant against an everyday food. And this could be a perfectly healthy food that you just happen to eat frequently, like broccoli, like quinoa, like apple, right? Walnut, very healthy foods. But this is why digestion is such a boring topic, but it is so essential to ensure that people have good, optimal digestion and that we maintain barrier function in the gut. These are not very sexy topics. It's not edge of technology, edge of scientific understanding. They just posted an amazing full free text on PubMed yesterday article about it. These are important foundational concepts of functional gut balance, but we ignore them at our peril. We marginalize or deprioritize them at our peril, because if we have maldigestion, especially paired with loss of barrier function, and people develop food sensitivities, then there can be all sorts of systemic disease at play that you're not going to find the results, the roots in the gut, unless you go looking for them. And so this will worsen over time as barrier function further degrades, as the tissue that's being damaged by the buildup of immune complexes like a knee joint or a shoulder joint becomes more and more degraded, right? Then people get higher and higher pain. Now they don't sleep well. Now they have insomnia. So their inflammation is up, their blood sugar's up, their cortisol's up. Now they have progressive insulin resistance. This is a classic cascade of disease that can happen that has its roots in the gut that you as a practitioner can learn to master. So we want to see the importance of digestion, the importance of nutrient absorption, the importance of protecting the precious gut lining and barrier function, especially in the intestines, and thinking about this and being prudent in when we recommend specific medications, using them for only as long as is absolutely necessary, and then working on healing the gut afterward. And stepping aside from a broad-based assumption that it's innocuous to the gut and the systemic body to use the mouth and the gut as a coin slot for drugs. Because as you're learning here through these examples, it is not innocuous. It has, in many people, significant downstream systemic effects. Most people, perhaps you who have been doing functional medicine or using functional medicine insight in your practice, maybe integrative with conventional practice for a long time, you too have seen cases of autoimmune disease that began because someone just started taking ibuprofen every day because maybe they injured their knee playing tennis, or they injured their shoulder playing golf, or they were in a car accident, right? Seemingly simple, worry-free roots. And this is how disease does not begin suddenly. It has slow building progressive roots that patients need savvy, keen practitioners to help them to identify. And once individuals have food sensitivities, they have to eliminate those foods in order to allow the immune system to have a chance of redeveloping a tolerance. We have to remove the foods long enough for the antibody count to go down. But again, we have to heal the gut. We have to get rid of what is degrading the gut barrier function or damaging the mucosa. And we have to make lifestyle changes that allow that to be sustainable. And I'm just covering the surface today of some simple things that can actually interfere with the maintenance of good gut barrier function and maintenance of optimal mucosal function as well. But I want to talk about two areas of the gut that are often overlooked. First of all, the mouth. It's fascinating to me that so often we think about dentistry as almost being like separate from medicine or separate from healthcare. It's like a separate specialty. But the mouth, my friends, is the top of the gut. It is the gateway to every other precious digestive capability and membrane function. So we must take care of the mouth, but we also must consider the health of the mouth in every clinical case we encounter. Of course we have to, right? Digestion begins in the mouth. Digestive enzymes are secreted in the mouth. There's a whole separate microbial world in the mouth. In fact, there's all sorts of interesting research being done to start to look at, the roots of downstream microbial overgrowth may be in the mouth. A part of the challenges we may see downstream with opportunistic commensal overgrowths like SIBO may actually begin in the mouth. And if people are struggling with any type of infectious dynamics in the mouth and they have dental caries or infected root canals, this type of thing, then absolutely all of that inflammation that is being courted in the mouth, we're swallowing all of the debris from that. And of course, what is happening in the mouth is not staying there. It's going up into the nasal respiratory membranes. It's part of what we inhale that influences the lungs. My goodness, we have to pay attention to the mouth. What kind of toxins do we put there on a regular basis in the name of personal hygiene and beauty products? What type of dental care do we practice? Hopefully non-toxic dental care. We've got to start focusing on these types of things because what is happening down in the esophagus or in the gastric cavity in particular may have its origins actually in the mouth, which also brings us to even more potentially medication-mediated dysfunction, right? What about inhaled steroids? Are those benign? Nope, just another great example of a coin slot, right? Because when you're inhaling a steroid, you are absolutely causing acute immunosuppression, right? In the mouth and in the nose and to some degree in the, laryngeal, esophageal area of the body. And what surprises a lot of practitioners is even though that is a local application of a steroid, it still suppresses adrenal function. It was one of the most fascinating things I learned 15, 17 years ago. But again, we need to understand what people are using. We need to consider the effects of medication. This is another reason why functional medicine is so essential, because even if conventional allopathic medicine has well intervened and people are enjoying the tremendous blessing of a targeted, appropriately described medication, which is a huge blessing, many medications with long-term use begin to exacerbate the very disease dynamic they were originally prescribed to counter. And so thinking about medications as being an intervention for a period of time until we have the opportunity or the space to more thoroughly assess the roots so that the need for the drug can be removed and the health of individual can be returned to the autonomy of the person and under the auspices of its own functional balances and resilient vitality. That is a whole nother threshold for effectiveness, efficiency, and affordability in healthcare that we're not talking about often enough. So it's not that drugs are good or bad. I think drugs are an incredible blessing for sure. but thinking about them as being a tool, not the only tool, but a tool in a rich, diverse toolbox that involves many different solutions, many different modalities and types of practices that are operating in the appropriate order of operations in a synergistic consultative way in order to support what this person needs right now at this point in time. And so, yes, we have to consider the health of the mouth, but what else do we tend to not focus on as much, right? We've got to go back and talk about bile and the gallbladder. So we were talking about motility and the digestive component of bile, but would it surprise you to learn that bile has antimicrobial properties? That bile is actually part of passive immune function? Well, passive only if you still have your gallbladder, right? Because it is not the same to have lost your gallbladder. When you have a gallbladder, the liver is fairly constantly generating with a rhythm of its own, but generating bile that goes through the biliary tree and it's collected in the gallbladder in a sac. And the rest of the GI tract experiences it in bolus form a few times a day. So it's not being constantly coated in a drip, 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 drip of bile, which is what happens when you remove your gallbladder. It is being protected from bile until we stimulate the eruption and the emptying of the gallbladder that has a larger, focused, limited bolus effect. And this includes not only the impact of bile with regard to antimicrobial function, which absolutely helps to counter dysbiosis, and a number of potent human commensal species like lactobacillus and bifidobacter have evolved to be resistant to the antimicrobial effects of bile, which is another fascinating example of the synergy that we have naturally evolved with. We want to have those microbes. We want to have those support for those commensals. We don't want to constantly be wiping them out with antibiotics. But also, we need good amounts of bile to be erupted in order to create secondary bile acids. All right, because there's a whole staged biochemical conversion of bile acids that happens in the gallbladder, and then as the bile acids move through the intestines, and secondary bile acids have metabolic functions. They play a role in insulin regulation. Tremendous interconnectedness across body systems in terms of what is affecting what. And so bile is also an alkaline substance that is critical for regulating pH in the intestinal cavity because different microbes thrive at different pH levels. Your digestive enzymes work optimally at different pH levels, right? You want to keep your gallbladder. You want to maintain the ability to expose the rest of the GI tract and then these other systemic functions to episodic bolus exposure to bile. Not the constant drip, 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 drip that's happening if the gallbladder's gone and we're just dripping bile constantly out of the biliary tree. Just because someone has had their gallbladder removed does not mean at all that the root causes of their gallbladder disease were removed. That's a bit like saying there's a criminal at large and we found a victim, so let's take care of the victim and hope the criminal goes away. That's highly unlikely, right? Because in the case of gallbladder disease, as I mentioned earlier, the roots of that are going to be upstream in the physiology, upstream in the biochemistry. And if you remove the gallbladder, but you don't address the thick, sluggish bile that caused the gallbladder disease, then there's going to be secondary disease development. It may take a little while, but it will happen because it's the logical outcome. If there's hepatic biliary congestion secondary to some degree of fatty liver, and you don't address that, then there's going to be the same stagnation in bile that may, like I said earlier, may lead to maldigestion of dietary fats, poor isolation and an uptake of fat-soluble vitamins in the body. And so it's not enough to remove victim body parts, right? The appendix is inflamed, so we take it out. They're fine, right? The gallbladder's inflamed, so we take it out. They're fine, right? You know, their shoulders, bone on bone. We take it out. We replace it. They're fine, right? No, they're not. What we've done is an important, perhaps, intervention if the state of disease of that anatomy was significant. But we haven't addressed the root causes of anything. We've just addressed the more acute manifestation of something upstream that will claim another victim body part given enough time. So if we want to practice thorough medicine, if we want to practice truly effective medicine that is about maximizing people's resilient vitality, then we need to be looking upstream. Our practice needs to be more comprehensive. And we teach at SAFM, and we know from experience over the past 12 years doing it, that every modality can play a critical role, a critical expertise and unique brilliance in providing care through the functional medicine lens. Our student body currently hails from 75 countries around the world and 22 different medical and health or wellness modalities. And so if what you have learned today resonates with you, I invite you to check us out at the School of Applied Functional Medicine. Schoolafm.com is our website. We have hundreds of clinical tips available on our public site. So excited to help further all of our comprehensive understanding and clinical savvy in maximizing the avoidance of disease, ideally, but at least the resolution of systemic disease by focusing on the gut. So I thank you all so very much for joining me today. Thank you so much. Have a great day.